the beginning, they can always watch the video.
That's great. Okay. And are you okay like this, or do you want, we can still see you.
That's great for the beginning, and it looks like you are recording already.
Yeah.
Okay, great. Okay, well, let's get started. My name is Claire Larkin. I'm a registered dental hygienist, and I love talking about collaborative dental hygiene practice, so I was really thankful that Nancy and I had a conversation a few weeks ago where she mentioned that in a lot of her discussion lately, that with all of the healthcare world being concerned about delivery of healthcare, that the idea of collaborative dental hygiene practice has actually come up. So Nancy contacted me and asked if I or anyone I knew would be available to do an infomar on collaborative dental hygiene practice. So that was the genesis of how today's program came to be. So I also want to add, as you can see by my title, that not just to talk about collaborative dental hygiene practice, but to give it an aspect of really now, I believe that this discussion is more important than ever. And the reason why I feel that is because of the concerns that we are being influenced by now at this time where we have a worldwide pandemic, we have higher than nationwide unemployment rates than we've had for decades and decades and decades. And there's a great need for action to reduce health disparities. But yet, also, there are hopeful reasons for why to talk about this. As healthcare had to do a 180 and reconfigure itself, all of a sudden now we realize that one of the things that is getting the healthcare population and the healthcare system still thriving is teledentistry. We've been talking about the ability to do teledentistry in collaborative dental hygiene practice for years. And I believe now that it's been proven to actually be a model for how healthcare can be delivered. I think that lends itself beautifully to collaborative dental hygiene practice. So I believe that it's more important than ever for us to expand the number of dental hygienists who are working in this workforce model, working in alternative practice settings. So I am here today, again, thanks to the Minnesota Oral Health Coalition and Nancy for spearheading this program. Also, I am technically retired, but I'm working on contract with a Normandale Community College Health Resources and Services Administration grant that is a 5-year grant that will be wrapping up its great work in the near future. So that is who I am actually representing today, although the topic of collaborative dental hygiene practice is just something I love to talk about anyway. And then I also wanted to acknowledge that I'm here today because Delta Dental has funded so much of the work about trying to work for alternative workforce models. So Delta Dental of Minnesota Foundation, we thank you as well for allowing this program to be there today. So what we'll cover today is I'm going to talk about collaborative dental hygiene practice, recognize the history, recent changes, describe the settings and the care delivery options. I could never cover the number of resources that are out there and studies that have been done and colleagues and professional associations that support collaborative practice. But I'll also showcase a lot of that on the Minnesota's 21st Century Dental Team Toolkit, or website that was part of my work for the last few years with the Normandale HRSA grant. What I won't be talking about today, and I'm sure some of you will be disappointed about that, is 2 topics that are present common and constant discussion is, well, when you're talking about collaborative dental hygiene practice, whose liability is it? Who covers whom? Who's responsible for whom? I'm not going to be able to cover that topic today. Also, the very complicated funding, billing, and reimbursement topic, I won't be going there at all today. That's an entire topic of its own, and I'll mention to you in a little bit what we had done in the past and hopefully what can be going forward. Also, I'm hoping that today's discussion, and this is being recorded, so for those of you who want to review it again or pass this program on to other folks, please know that what I'm feeling good about is that I want to have this presentation stimulate the idea of mentorship, to gather those dental hygienists and dentists who have been involved with this workforce model for years and years and years, and to be mentoring, which is something that has been asked for a lot by people who, especially new graduates who are interested in this, or dental hygienists who want to take a different path to their practice. Hopefully, we can support one another in that endeavor, and also continuing to talk about alternative measures and means of oral health care delivery, which we're finding right now with this unprecedented time that alternatives is really the name of the game. I also will just interject quickly here that I do recognize that my photos that I'll be showing in this presentation are old. They're pre-COVID, pre-pandemic photos, and without question, those photographs, as we move forward with the changes to oral health care delivery, will be updated to represent the major professional and life-changing things that have had to happen, all for the good, I believe, as a result of the pandemic that we're going through right now. So let's begin with a historical reference. You may have met Mary Otto when she was here a few times in Minnesota. Mary Otto is a Washington, D.C. based journalist who covered healthcare, in particular healthcare for those who live in poverty. Mary has written a book, as you can see, called Teeth, a very simple title. I have the book here. I love this book, and I just wanted to show you that if there's any indication by how many sticky tabs someone has on a book that marks passages and important things for the author's work, you can see that I really like this book a lot. Mary covered the story in 2007 of 12-year-old Diamante Driver, who really, sadly, his death did bring about change and attention to oral health access issues. Diamante was a 12-year-old state of Maryland young man who technically had dental insurance coverage through Medicaid, but the family was unable to achieve or to access dental care, and so sadly the child died from a bacterial infection caused by a tooth problem. So that was a very sad story that stimulated a lot of the access to care issues. And what I really like about Mary's book is that in great detail, Mary addresses the question that we hear all the time in our health and medical circles is, how did it happen that the mouth was disconnected from the rest of the body in the healthcare system? And you'll find, if you haven't read this book, that Mary details that extensively about the history of how medical dental morphed from what it had been to what it is today. So please read the book. The Minnesota Department of Health Oral Health Program is required, per their funding from the Centers for Disease Control and Prevention, to offer a 5-year open mouth statewide survey of third grade students. I was part of that project in 2015 as an employee of the Minnesota Department of Health Oral Health Program. And the information that came out of that was not surprising, that good oral health is not shared equally by all Minnesotans. That two children, I'm going to move this down, 2 out of every 10 third graders have untreated tooth decay. It was found that 5 out of every 10 third graders had experienced caries, dental caries. And caries experience is described as both untreated and treated tooth decay. The study also showed that third graders enrolled in rural public health schools were 1.3 times more likely to have experience than were their urban school counterparts. And Hispanic third graders were 1.4 times more likely to have caries experience than their white, non-Hispanic counterparts. So oral health disparities really do exist here in Minnesota. So what is collaborative practice? When you hear the term collaborative dental hygiene practice, I often wonder if your mind goes to the same place that my mind used to always go to. And that was a jumbled word cloud of terminology and words and concepts. And for example, people will frequently confuse the Department of Human Services with the Department of Health. We have the Department of Labor that has influence on what we do, on our scope of practice and who can be working in the profession. We hear about low income. What is a nonprofit? What does the Board of Dentistry have to offer us? Continuing education, rules, statutes. Your mind can just swim when you think about collaborative dental hygiene practice. But I want to point out that collaborative dental hygiene practice started in 2001. And at that time, the statute, or what is a law, was titled Limited Authorization for Dental Hygienists. And the reason why it was titled Limited Authorization is that in the early days, literally the scope of services that a dental hygienist could provide in community settings was limited to a certain set of procedures. And we'll talk about how that is expanded in just a little bit. In those early days, there was a lot of activity to try to get the model understood. And I was on faculty at Normandale at that time, and we held numerous info sessions, brought in someone from the Minnesota Department of Human Services to talk about the billing. Delta Dental staff came in and talked about health plans. We had vendors come in and show how to use the portable equipment. And one of the things I smile to myself about is thinking back on what a big deal that was back in those early 2000s when we had a distance, an ITV presentation on collaborative dental hygiene practice where it was transferred out to multiple settings throughout Minnesota. And when you think of how innovative that was at the time, and today it's just commonplace that we're doing everything by electronic and virtual communication. And so I smile when I think of where we have really come from. So a lot of activity happened back then, and today's Infomar is an example of the fact that it's coming back again. The interest is being generated about how can we do alternative oral health care delivery by doing this in community settings. And so even though there are a lot of licensed oral health professionals that are not familiar with that, this is a great step. So again, I thank you, Nancy, for allowing this opportunity today. Collaborative dental hygiene practice is, I love this definition, it's a dynamic process, a commitment that empowers the participants to blend their talent to achieve a goal that neither can do alone. I just think that that is so true. Collaborative practice in Minnesota enables a dental hygienist to provide care in community, or what we often refer to as non-traditional dental settings. In Minnesota, again, we utilize a written collaborative agreement. So that collaborative agreement is between a dentist and a dental hygienist. I want to point out very clearly that collaborative agreement, collaborative dental hygiene practice in Minnesota is not independent practice. Every state has some sort of version of how dental hygienists practice in a, I shouldn't say every state, many states have a model of how a dental hygienist can practice in an alternative way. Here in Minnesota, we need a written collaborative agreement. One example is our friends to the east of us in the state of Wisconsin. Their dental hygienists can work in a certain set of community settings without having to have an agreement. And just within the last year or so, collaborative practice hygienists in Wisconsin actually are working in medical dental settings with a new innovative idea. So keep an eye on that. And medical dental is absolutely where we want to be going. But it is not independent practice. As I mentioned, the original law was enacted in 2001. At that time, it was termed limited authorization for dental hygienists. Throughout those 20 years, there have been great changes made to strengthen the law. For example, in 2015, many partners got together to work with the National Governors Association to build a framework that would evaluate what was really needed. That was really trend-setting to have that happen, to be working with the National Governors Association. We had a collaborative dental hygiene practice advisory group years ago, and through the HRSA grant funding with Normandale, that advisory group was reignited, and we're still meeting quarterly, and there is a lot of work, a lot of advocacy that goes into that, and we have members of the health plan, professional associations, state departments, educators, clinical practice dental hygienists, collaborative practice hygienists. A lot of work, a lot of thought has been put into those collaborative practice advisory group meetings. And the beauty of why the changes came about in 2017 to update and strengthen the collaborative practice law was because there was such collaboration. There was not any dissension about what could or could not be done. So we were so grateful that those changes came about. So there were additions and deletions. A few of the important changes to that law was that in the early days until 2017, a dental hygienist was required to accrue 2,400 hours of clinical dental hygiene practice before they could even think about working in a collaborative practice environment. And what happened and what was realized, and the reason why those hours were thankfully removed from the collaborative practice statute, is because dental students, dental hygiene, dental therapy, dental assistant, all of those education programs now are working toward having their students leave the educational institutions within a mindset of community service. As a dental hygiene educator, I know that we constantly talked about how to serve all people. The majority of the clients that the students saw in their educational clinical programs, those were underserved or uninsured clients. So the students were all energized and enthused when they were in the educational program. Then they graduated, and dental hygienists moved out into the traditional dental hygiene practice because they had to accrue 2,400 hours of dental hygiene work until they could start considering collaborative dental hygiene practice. That's totally gone now. We're really looking forward to the time when those dental hygiene students will be that energy that will sign on to working, even if it's just a tiny little amount, into a non-traditional dental hygiene practice. Another really exciting thing that happened with this 2017 change is that licensed dental assistants can now team with a collaborative practice dental hygienist in community settings, and that licensed dental assistant can now be doing a limited scope of practice in the setting without having a dentist present. This is huge. So let me give you an example. I'm very familiar with school-based dental sealant programs, and the dental hygienist in those school programs is the person who determines which teeth can be sealed. So the dental hygienist will make that determination, pass that information to the licensed dental assistant that is on that community health program. The dental assistant can then place the sealants as determined by the dental hygienist. What this has the opportunity to do is to expand the number of kids, students that can be seen in a school, to lessen the time that the program needs to be in the school. And this is really going to be very important, as it's totally unknown how schools are even going to be functioning and how a school sealant program can continue to move forward. But it's really important, and having that opportunity for a licensed dental assistant to be able to be teaming with that licensed dental hygienist in a school setting, that's a really big deal. So the populations that are served by collaborative practice dental hygienists are viewed in the left montage of photos. You can see that there are young children, a school setting in the upper level photo, elderly on the lower right, long-term care setting. The woman in the middle photo on the left, the woman dressed in black, is enrolled in a maternal child health program. And many of you have heard of the Women, Infant, and Children, or WIC program. Those are all potential settings that a collaborative practice could really work. It could be a little bit of time, it could be a lot of time, but those settings are what we call the non-traditional community settings. And the way that dental hygienists are involved in that can be varied. For example, on the screen you see that dental hygienists might be an employee of a dental practice. There might be a traditional dental practice that wants to authorize their dental hygienist to go to the local nursing home one day a month, or however often would be important and available and needed. Or the community Head Start Center. Many of you probably know that Head Start children are required to have a dental exam or a dental assessment to remain enrolled in the Head Start programs. A dental hygienist can go and do that assessment in a Head Start setting. And that could be an employment mechanism. It could also be a volunteer mechanism. And then another model that some dental hygienists here in Minnesota have taken on is that they provide care through nonprofit status and a board of directors. So the variety of the workforce model of how it's carried out is different, but it all works. How does collaborative dental hygiene practice work? These are some pictures of collaborative practice settings. So on the left, you can see that a mobile unit drove and provided care out in the parking lot at Sibley High School and many other schools in the metro area for sure. Upper right is a large long-term care setting. That is another example of where collaborative practice could work. Lower right is a large federally qualified healthcare medical system, Whittier Clinic. And then the picture in the middle of the left is a school setting, which I think many of us are familiar with. These are settings in which medical dental integration really can happen. In the schools, the dental hygienist works in collaboration with the school nurses. That really is a very fitting place for us to be involved. How does that care happen actually in the setting? You can see the photo on the left where one of the staff members has portable equipment that is transported with a van, and the portable equipment is transported into the setting where that staff member will be for the day. Or the photo on the right is large, full equipment dental units as we know them traditionally in dental settings that have been fitted out with the capability to be wheeled into the facilities. And this particular organization has trucks that transport the equipment from place to place to place because it is so large and so very full service equipment. This is what that equipment looks like. It's traditional dental equipment on wheels. Here's what a school-based oral health setting would look like. And again, this was pre-COVID, but I want you to see how compact and easy this really can be with the portable chairs. You can see the clinician on the right has we can have a good view of the compressor system, the suction, the handpiece, and it really can work in non-traditional settings. This is a great example of a school setting. So the goal with all of those settings is those collaborative practice dental hygienists screen, they assess for risk, they provide the primary prevention and intervention care so that we don't have to move the students, the residents, into the restorative phase of dental disease. Again, doing risk assessment, assessing, early intervention and prevention. I can't stress that enough. What is a collaborative agreement? Where do I get one? And how do I create one? These three questions are asked of we who have been involved in this for a long time. Questions asked constantly. The Minnesota Board of Dentistry has a really nice definition, so I've taken this directly from the board. Collaborative dental hygiene agreements are between dentists and dental hygienists. They authorize the services, they define the settings, and the last part of this definition is important. As specified by law, and when a dentist need not be on site. That's what the collaborative agreement can convey, is all of that information. A collaborative agreement would be needed in these sorts of situations. For example, on the upper left is likely an early childhood center where the equipment is brought in temporarily. On the upper right is another example of a school-based dental sealant program where there are multiple providers, assistants at the chair, portable equipment set up on a temporary basis in a school. And then the lower right picture is equipment and professionals there serving in a long-term care setting. A collaborative agreement is needed in these situations. A collaborative agreement is not needed in certain situations. So, for example, if a dentist is temporarily away from the office, the picture on the left, that montage of 4 pictures, is a continuing education conference. So, for example, if the dentist was away at a multi-day continuing education conference, the dental hygienist would not need a collaborative agreement to remain seeing clients in the traditional dental setting. And on the right, I get asked this question a lot, especially when the statewide screening survey is in place, is whether or not a dental hygienist needs a collaborative agreement to do an oral health screening. And the Board of Dentistry has determined that because there is no diagnosis made and there's no treatment plan being generated, an oral health screening is literally just that. It happens to be a dental hygienist doing the screening, but a collaborative agreement is not needed. And at this point, I do want to just interject whether or not a collaborative agreement is needed. Collaborative dental hygiene practice was never designed and never meant to be used in traditional practice settings. We realized that in the early years, the workforce model had some situations in where collaborative agreements were written, were drawn up, and submitted to the Board of Dentistry as collaborative agreements. And the intention for that was well-intentioned. The idea was thinking that a dental hygienist who would have a collaborative agreement in a traditional dental setting could then be, in quotes, seeing new patients first. And for those of you who are not oral health professionals, that is a discussion topic that comes up a lot, whether or not a dental hygienist could see a new patient prior to being seen by a dentist who would be providing the diagnosis. And again, as I said, this was well-intentioned. However, what was realized when the data was being looked at was that even though well-intentioned, registering those collaborative agreements with the Board of Dentistry indicated then that there were a larger than actual number of collaborative agreements out there, thinking then that there were a larger number of dental hygienists who were out working in non-traditional settings out in the community. So that was not in the original intention back in the early 2000s to have collaborative agreements written for traditional dental settings. Collaborative dental hygiene practice was determined to be a solution for non-traditional dental settings. And another reason why, since 2017, a change to the dental hygiene scope of practice is that now all of the services that a dental hygienist can practice and provide in a clinical dental setting are under general supervision, meaning that the dentist does not need to be present at all times in that dental practice setting. And they work under general supervision. The dentist just needs to be aware of and authorize those services. So that again was another big change in 2017. Another question that I get frequently is whether or not a collaborative agreement is needed to go into schools or community settings, for example, a senior center to provide oral health education. If you are strictly going in and demonstrating, as this picture shows, a dental hygienist doing brushing instruction with those young children, a collaborative agreement is not needed for that situation because literally you are out there educating. You are not doing hands-on oral health care. So during February, when dental office staff are invited to come into the classroom to do oral health lessons, again, a collaborative agreement is not needed for that. However, another question that I'm asked, and as my colleagues asked a lot, is whether or not a collaborative agreement is needed for a dental hygienist to go into, say, for example, a long-term care setting and to provide what is they refer to as daily cares of brushing and flossing. To me, that's a different situation because you are actually would be doing hands-on in the mouth care for the dental patient or the resident of that facility. So on that particular situation, I encourage you to call Bridget at the Board of Dentistry. The Board of Dentistry is there to guide. The Board of Dentistry is always extremely helpful with questions that we have. So if you have any great ideas about where you would like to perhaps do a workforce model, check with the Board of Dentistry. They are the absolute determining factor for what is and what is not authorized. So keep that in mind. So the other questions that I posed earlier that I said that people ask continually is, where do I get a collaborative agreement? How do I create one? Well, part of the Normandale work that I'm doing is to have created what we call the Minnesota's 21st Century Dental Team Toolkit. It is a resource that you can find hopefully everything you need when you're considering doing collaborative dental hygiene practice. And this is a screen capture from the dental hygiene and community settings section. You can see that the first highlight that I have shows a toolkit, and in that drop-down menu, there are just a zillion references. Also there, when people ask, where do I get a collaborative agreement template? You can get one right there at that drop-down menu from the website. Also, the Board of Dentistry website has the same exact collaborative agreement template, as does the Minnesota Dental Association. We worked, thanks to Maida Hojic from the Minnesota Dental Association, to get that collaborative agreement reviewed by the Minnesota Dental Association. So that same template is available here on the website at the Board of Dentistry or at the MDA website, and all entities have agreed upon that layout of that template. So do know that that's available for you. And at the bottom of the screen capture is a circle I've highlighted, a help desk, where you can submit any questions you might have. If you want just a cursory answer to a question, log on to that drop-down menu and submit a question. And what happens with those is we gather a little group of people to talk about how best to answer that question, and we do get back to you with that answer to the question. The middle highlight that I have shows coffee talk videos, and let me change my screen and talk about that. So through the website, as part of the HRSA work, we developed a series of 5 coffee talk videos. They are 10 minutes or less, 5 separate videos where we address different aspects, similar to what I'm doing today. And the players in that project were Jean Anderson, a retired dental hygiene educator from the U of M, myself, retired educator from Normandale Community College, and under the direction of Deb Sid, who is also a retired dental hygiene educator from Normandale. And we worked with Pavel, just an incredible videographer from Normandale, to create these Coffee Talk series. And the beauty of this is that Bridget Anderson from the Board of Dentistry, Executive Director, reviewed all of these Coffee Talks and determined that if a person views all 5 of the Coffee Talks and downloads the accompanying review questions that go hand in hand with the Coffee Talks, that by doing that and filing those answers to the questions and the bio and putting those in your professional portfolio, the Board of Dentistry has determined that you can obtain 2 continuing education credits in the fundamental aspect, fundamental continuing education credits for your professional portfolio. So the credits are free. You can learn about collaborative dental hygiene practice and be rewarded with continuing it at the same time. So I encourage you to check those out as well. We had a lot of fun doing them. So regarding the collaborative agreement, the question of how do I create one? Where our colleague Deb Jacoby, who's pictured on the left from Apple Tree Dental, is sitting in this picture with Ann Bottrell, the Executive Director of the American Dental Hygienists Association. Deb very gratefully created a video tutorial that walks you through how to create a collaborative agreement, step by step by step. This collaborative agreement is just a screenshot of that blank agreement that I mentioned earlier. And of course, it's going to require some just straightforward information about who is the dentist, who is the dental hygienist, what is your license number, essentially. But also the beauty of the tutorial is Deb walks you step through step on certain protocols that are required through the statute that must be reflected in a collaborative agreement if they apply to your traditional, non-traditional dental setting. So medically compromised patients is one that is required. And Deb walks you through very well how that particular section can be addressed. And then also, very wonderfully is in this video tutorial, Deb mentions about best practices that can strengthen your program, strengthen your collaborative agreement. And so again, these are not required by law, but they really get you to thinking about how do I work in the community that I want to be working in. And one best practice that is just what to do with the collaborative agreement. How do I work with the settings? How do I develop a memorandum of understanding? There's a whole lot of best practices that are offered through this tutorial. So please take a look at that. So where do we go from here? Where are we going from here? Since the early days, we know that change can happen through collaboration. We're finding that now as we're needing to do a turnabout with our oral care delivery as a result of the pandemic that is upon us right now. But we know that coming together with partners such as we see here on the screen, this is how change does happen. We worked a lot with the Minnesota Department of Health, and in particular, the Office of Rural Health and Primary Care. And I want to let you know that Nancy is going to be providing you with a resource guide or a resource sheet. And on that resource sheet that you're going to be seeing is a dental hygienist fact sheet that Laura McLean has done for the Office of Rural Health and Primary Care, describing the studies that they have done about collaborative dental hygiene practice and determining how we can actually find out the significance, the ability, the change that is being made with alternative care delivery. So those studies that come out from the state level, the studies that have been done around collaborative practice and many other venues are so important to making this realization that this really can work. And how can we expand those persons out there working in this workforce model? So thank you again to all of these partners that we've been working with for many years, Department of Human Services and the Minnesota Department of Health Oral Health Program equally as well. So I've got some must-dos. Please check out the website. The top photo is one of the days of the screening for these coffee talks where Jean and Deb and I are set up in a video situation. It was really fun doing those videos. We hope you like them. We've had some feedback that people say they were kind of dry, that they could have been more upbeat, but we're really proud of those and I hope you find them helpful. The photo on the left is a video that is available on the website, and the person on the left is Eva Romero, who is a collaborative practice dental hygienist and also she's dual licensed as a advanced dental therapist. And there's a great video on there where she talks about a day in the life of a collaborative practice hygienist. And then we're very grateful for a couple other tutorials that are on the website that were created for collaborative dental hygiene practice specifically by Nancy Frank Wilson, Executive Director of the Minnesota Oral Health Coalition. Nancy created these videos, the first one on grant basics, and as we all know, funding is an important factor for any program that needs to sustain. So the grant basics one is very informative. And then Nancy also did another one that's available on the website called Nonprofit 101. And we can't thank Nancy enough for taking her time to create those videos. Another colleague who is doing a benefit for uninsured and underinsured persons is Kathy Jo Gunvalson, and she's pictured here on the left. And she worked for many years with the Red Lake Comprehensive Health Services as their school-based program director and school-based sealant program director. Let me be clear on that. Kathy Jo is now volunteering her time with the National Center on Early Childhood Health and Wellness to be what is called a dental hygienist liaison. So every state has a dental hygienist liaison, and the purpose for that volunteer position is to help promote oral health for pregnant women, to promote oral health for children enrolled in Head Start and children enrolled in child care. So if you have any volunteer time, I'd love for you to contact Kathy Jo Gunvalson to see how you could contribute in your particular area. Again, it's a volunteer position, and Kathy Jo is very dedicated to that position. So thank you. Recently, there has been movement to create more opportunities for those providing mobile dentistry. I believe it was in February, the first annual Mobile Dentistry Conference was held, and One of the spearheaders of that was Melissa Turner, who many of you may know. She is a dental hygienist who had lived in Minnesota at the time and now lives in a different state, but is very active in promoting mobile dentistry. And you've maybe followed some of Melissa's writing in some of our professional journals, for example, RDH magazine. And the most current article written was that idea that if a dental hygienist wants to move into a non-traditional setting, how can they engage in an entrepreneurial spirit? I think you'll find the article very interesting. And the next Mobile Dentistry Conference will be in March of 2021, and it will be in Orlando, Florida. So here's what we did cover today. Again, through leadership of my work and many of our partners, we've been working toward the idea that collaborative dental hygiene practice is an alternative option to traditional dental hygiene practice. It's not a required, it's an option. There are multiple community settings and care delivery options. Through Colleen Brickell's work with applying for the HRSA grant for the last 5 years and leading a lot of that initiative, we've created that toolkit for you that has more information that you can ever hope to have. But I do ask that if you see or if you don't find something there, or if you see something that you think maybe should be explained better, please contact me. I really want to hear feedback from people about whether or not you've found the website helpful, or we like to call it the toolkit, the go-to place, the one-stop shop, whatever you want to call it. But please let me know if there are things that you want to see there or that could be explained better. And then, as always, no matter if you're oral health professional, traditional medical health professional, I always recommend that please stay active with your professional associations. We really can be moving toward access for all if we all work in collaboration and become creative and make collaborative dental hygiene practice work. So with that, I want to just mention again that my funding for my work was from the Health Resources and Services Administration. So I'm happy to take any questions now, if any of you have any. And I should give say a caveat to that, though, is that if I don't have an answer, I'm not going to make up an answer. If your question is not being able to be answered today, I promise you will get an answer to it. I'll work with my colleagues and specialists on that. So thank you.
Thank you so much, Claire.
You're welcome.
This is always important, but I think we've all been reminded about disparities, and especially health disparities. We know that it's particularly inequitable in oral health. So when you talk about this work and you mention access, or you concentrate on access, like I said, it's always been important, but I think it's more important today than ever.
Yes, I agree.
Does anyone have any questions for Claire?
And if you don't have questions today, submit them through the help desk, please.
That's right. And I just wanted to say that I actually have a couple of Mary Otto's books. I have the book Teeth. I have it in CDs, and I have it in book form. So if I'll give 2 away to the first person that that emails me at Nancy at Minnesota Oral Health Coalition.org.
Wow.
Yeah, because I purchased them when she came to speak, and I've been using them as giveaways. And I thought, well, this is a perfect time since you've talked about, you know, how important her book has been. So yeah, the first 2 people that email me, and you can tell me if you want the CD or the book. Let's see. So Deb, it says, Deb, can I read this?
Sure.
Okay. Or you can go ahead and do that if you want.
Well, I just said it wasn't a question, but a comment. I wanted to thank you guys for putting on this webinar. And I couldn't help but see that Dick Dirks is on the attendee list, and Claire acknowledged him before the recording began. But Dick has worn a number of hats during the time that we've been working on collaborative practice. And I just wanted to call out that I think of him as one of the people who helped move this forward,
I agree.
whether with the Dental Association or with the Board of Dentistry. So thanks, Dick. It's great to see your name. We're kind of the old guard. And thank you guys for putting on this webinar.
Well, and thank you, Deb, because you're right up there with Dick and Claire and the others. So thank you for all your leadership and, you know, just your commitment to oral health and access. It makes a huge difference in the lives of Minnesotans. So thank you.
You're welcome.
Well, should we end? And this recording will be available. Okay, I'll send a link out, but it'll there's a link on our resources page on our website as well, minnesotaoralhealthcoalition.org. Claire, thank you so much.
This was great. Thank you for the opportunity. And stay in touch and send me questions. Thank you.
Good.
Have a good rest of the day, everyone.
Yeah, thank you. Bye, everybody.
Bye.